Good afternoon. I'd like to welcome everybody to the CSOHIMSS Lunch and Learn webinar. Today's topic is the CMS Quality Reporting, tying it all together in the shift to value-based payment. Today's presenter will be Saavedra from Health Services Advisory Group. Before we get started with Carol's presentation, I would like to share a little bit of information on CSOHIMSS. Also, a few housekeeping items before we get into the CSOHIMSS information. Today's handouts that include the CPHIMSS, CAHIMSS, CEU form, presentation slides from Carol, and these introductory slides are available in the handouts function that's built into GoToWebinar, and you can also find them on the CSOHIMSS website under the events information, and then there's a section for past events. The slides are already posted. We are also recording today's presentation, and it will be available on the CSOHIMSS YouTube channel at the address that's provided. We wanted to share some CSOHIMSS contact information. Our primary means of sharing information is our webpage, which is available at csohio.himsschapter.org. Also, if you do have questions, suggestions, feel free to email either csohio.president or csohio.info@himsschapter.org. We do heavily utilize social media to share information on our upcoming events, links to important health IT information, and just to stay in contact with our CSOHIMSS members. We are available on Facebook and Twitter and on LinkedIn. We would like to thank our sponsors because without them we would not be able to provide the educational opportunities in our conferences. Our premier level sponsors, these are our top level sponsors. We'd like to thank EHR Integration Services, Expedient, Logicalis, Sagacious Consultants, Allego Health, Ahead, Cover My Meds, and Merge. Those are our premier level sponsors. Our elite level sponsors are Metasource, Obix Perinatal Data Systems, Information Builders, Blue Orange Compliance, Availity, and Tech Systems. Our partner level sponsors are Time Warner Business Class, Dimension Data, Physician Technology Partners, Rico USA, and BCG Systems. We'd also like to share some information on some other upcoming events provided by CSOHIMSS. The first will be our 2015 Fall Conference. This is scheduled for next Friday, October 23rd in Dayton, Ohio at the Mandalay Banquet Center. The topic or the theme of this conference is population health, and we've titled the conference So Long and Thanks for All the Data, the Conference on Population Health. Registration is open. There are still tickets available. You can go to the CSOHIMSS website at csohio.himsschapter.org to get the link to the registration site, or if you just go to Eventbrite and search for CSOHIMSS, you can find this conference as well. This is going to be we have great speakers lined up. Great opportunity, a very affordable conference here in Ohio. Please consider attending. In April, we will have our 9th annual Ohio Health Information Technology Day. This will be held at the Ohio State House Atrium. This is an advocacy event. This year will be focused on interoperability. We do not have a registration site set up, but we do ask that you watch the CSOHIMSS website for more information and for when the registration link does become available. In the spring, we have a cybersecurity and HIPAA-focused conference scheduled. This will be held in Columbus, up in Dublin, on Friday, May 20th at the Conference Center at OCLC. The title of this conference will be Hack, Is That a Cough or a Cybersecurity Breach? We are also accepting proposals for speakers for this event. If you are interested in being a speaker, feel free to contact me at the csohio.president email address that was provided earlier. We do have some other Lunch and Learn webinars scheduled in the future. These are the second or third Wednesday of each month. We go the second or third Wednesday because we have a few holidays in there, and so we will bump the Wednesday session one week or another just to accommodate folks around the holidays. The future Lunch and Learn webinars that are scheduled are, the next one will be Wednesday, November 18th from noon to 1. The topic and theme will be the Stage 3 Meaningful Use Final Rule. Presenters will be Kathy Costello and myself. I'm Scott Mash. We have another Lunch and Learn scheduled for Wednesday, December 16th. The topic or theme will be the Meaningful Use Required Security Review, and the presenter will be Mr. Jim Carroll from the Akron Regional Hospital Association. We don't have a registration link set up for this yet, but it will be coming soon, so keep an eye on our webpage. We do have these sessions scheduled out through our fiscal year, so January, February through June, we have the dates scheduled. We are looking for speakers. If you are interested in presenting, please contact me. The topic can be any healthcare IT related topic. We do ask that if a vendor is interested in presenting, that it not be a sales presentation, and that the vendor partners with one of their customers and do a focused presentation on, you know, a solution or service or whatever. So if you would like to be a presenter, please contact me. And now I'm going to turn it over to Carol, who will be our presenter today. I have to unmute Carol and make her the presenter. So it may take a second for your systems to transition, but while that's transitioning and she's sharing her screen, I would like to introduce Carol. She is the Health Informatics Specialist for the Health Service Advisory Group. Again, her presentation is titled CMS Quality Reporting, Tying It All Together in the Shift to Value-Based Payment. And Carol, for 8 years, has served as a quality specialist with Ohio's Quality Improvement Organization and has delivered numerous presentations explaining CMS quality reporting programs, Medicare's preventive services, and techniques for improving clinical quality measure performance to primary care physicians, stakeholders, and beneficiaries.
Okay. Thanks for the introduction, Scott, and thank you to CSOHIMSS for inviting me as a speaker today. Again, my presentation is CMS Quality Reporting, Tying It All Together in the Shift to Value-Based Payment. My name is Carol Saavedra, and I'm a Health Informatics Specialist with Health Services Advisory Group, or HSAG. We are Medicare's Quality Innovation Network Quality Improvement Organization for Ohio, Arizona, Florida, California, and the U.S. Virgin Islands. So today I'd like to share my objectives. First, I'll briefly describe the Centers for Medicare and Medicaid Services Value-Based Programs, which are PQRS, or Physician Quality Reporting System, and the Value Modifier. I'd like to summarize the 2015 incentives and 2017 payment adjustments associated with those programs. We'll take a look at the mid-year and annual quality resource use reports and explain what those are and what information can be found within them, and also demonstrate which actions providers can still take now for successful 2015 reporting for the quality programs. So, in January 2015, the Department of Health and Human Services announced some aggressive goals in shifting the payment from fee-for-service to value-based payment. So this slide is an illustration of that goal. By the close of 2018, the goal is to have 90% of Medicare payments linked to quality, 50% in alternative payment models like ACO, CPCI, and the balance of that 40% of fee-for-service being linked to quality. And that's where we find the hospital value-based purchasing and the physician value modifier, which I'll be speaking about today. Since you see here that a majority of clinicians will still be, at least in some way, serving beneficiaries who are receiving care under the Medicare Part B fee-for-service, that's where these programs apply. PQRS and the value modifier are for Medicare Part B fee-for-service providers, and they don't apply or may not apply to providers in alternative payment models like ACOs or CPCI. So if we look at this screen, as we shift from payment for service to payment for quality, 2015 is a key year in that payment amounts will begin to be affected by performance data for physicians in groups of all sizes. It was a phased-in approach, but as of 2015, performance in this year will affect payment for physicians in groups of all sizes. So this slide illustrates what's at stake for providers' reimbursement based upon not only their participation in quality programs, but performance rates of clinical quality data that's reported as well. So let's talk about the Physician Quality Reporting System. The Physician Quality Reporting System, or PQRS, is a quality reporting program that encourages individual eligible professionals, or EPs, and group practices to report information on the quality of care to Medicare. And this began, we can see the evolution here, in 2007 when the PQRI, or the Physician Quality Reporting Initiative, was voluntary. As of 2014, the PQRS program became mandatory in that penalties would be assessed for providers that did not participate. And also in 2015, we see that and the value modifier are mandatory. So here we see that it's evolving from an incentive to report to a penalty to report, but now we also have avoiding the penalty for reporting PQRS, but also the performance that you report within your PQRS quality data will influence your value modifier, which I'll talk a little bit more, which can result in an upward, neutral, or downward adjustment. So there are two options for eligible providers to participate, and an eligible provider or EP is a physician or practitioner providing services to Medicare beneficiaries that are billed under Part B covered professional services under the Medicare physician fee schedule. So we often hear, does this apply to me? Am I an eligible provider for PQRS? The answer is, if you're billing Part B of the Medicare physician fee schedule, the answer is yes. And you can report as an individual. A provider can report as an individual or as a group. As an individual, it's by the NPI, and under the group, they would select the group reporting practice option, or GPRO, and then their performance and cost is analyzed by the tax identification number. One thing to note here is that registration to report as a group did close on June 30th, so the GPRO option is off the table if you haven't registered, if the group hasn't registered already. So for 2015 PQRS reporting, we have 9 measures across 3 quality domains. Since this is a very high-level overview, I won't get into measures groups or specialty sets, but for 2015 the requirement is the same as last year, to report on 9 measures across 3 national quality strategy domains, and those are the same domains for the EHR incentive program or meaningful use. So this is for services provided January through December of 2015, and then we'll submit that data in the beginning of 2016 in January and February. It's important to note here that there are several different reporting options. There's a pretty complex algorithm to determine which reporting options would apply to your group based on the size of your group, the specialty makeup of the group, the capabilities of the EHR, etc. If you're still facing these decisions, you'll want to reach out to make sure you get the help you need, but remember the group registration window has passed, so that takes the group reporting option off the table. And also, since performance is based on the calendar year and we're past halfway through, reporting claims at this point wouldn't be an effective option either. So the process for feedback. CMS completes the evaluation of PQRS data in March through August of the following year, and then they will send out make the quality resource use reports available that show how the provider's payments will be affected based on the value modifier from 2015 cost and quality, and then the payments are effective starting January 1st of 2017. I'll talk more about QRURs in just a moment, but let's look at the value modifier. It's important to remember here that the performance period is for 2015, payments would be adjusted then in 2017. So we have the performance period and then the year in between while the analysis is being made and the quality resource use reports are distributed, and then payments are adjusted at the beginning of that following calendar year. So let's look at the value modifier, VM as we affectionately call it. In my old practice manager mindset, when I heard modifier and CMS, I thought modifier 25 or 59, etc., CPT modifiers, but this is very different. And I'm surprised at how many providers aren't aware of the value modifier. The value modifier provides for differential payment under the Medicare physician fee schedule based on the quality of care furnished compared to the cost of care during a performance period. So the value modifier is an adjustment made on a per-claim basis to Medicare payments for items and services under the Medicare physician fee schedule. So think of it as a modification to payment. The value modifier was phased in, as I said, depending on group size, but this year CMS's definition of a group is now 2 or more providers. So any 2 or more providers reporting under one tax identification number, their value modifier is determined at the tax identification number level. How does the value modifier work? CMS collects cost and quality data. Part of that is through the PQRS measures that are submitted, and also CMS tracks per capita costs for Medicare Parts A and B. At that point, they group providers into quality tiers, and those final scores are tiered and the providers are assigned modifiers. And then Medicare payment is adjusted based on tiering. High-performing groups will receive payment boosts. Low performers will see a payment reduction. But remember, failure to participate in PQRS will result in the maximum penalty. And if you remember the slide we looked at the very beginning, if you don't report PQRS, they don't have the quality measure to calculate your value modifier, so you would automatically receive not only the PQRS penalty for not reporting, but you would also receive a downward adjustment on the value modifier based on not having PQRS information. So what you do in 2015 is important. Those who satisfactorily report for the 2015 PQRS program year will avoid the 2017 PQRS penalty, and also the 2015 data determines 2017 adjustments. So if you report, you avoid the 2017 PQRS penalty, and then based on that performance, on the data that you've submitted, in 2017 you could see a positive, neutral, or negative value modifier adjustment depending on the size of the group. And we'll look at that in just a moment. So tying it all together, how does PQRS and the value-based modifier work? If we look at this screen, we can see on the left-hand side there are sizes of groups. We see solo physicians, their reporting options, and then we also see groups of 2 to 9, 10 to 24 and up. You'll see, I wish I had a pointer, I'm not sure if you can see my arrow. The last 3 columns here are very important. PQRS reporting. If they report PQRS, you can see all down the line, report PQRS for 2015, you avoid the 2017 PQRS penalty of 2%. And then we look at what happens with the value modifier if you're a PQRS reporter or a PQRS non-reporter. You'll see the non-reporter column on the right-hand side shows that there's a downward adjustment there for the value modifier in addition to the PQRS penalty. So this is a graphic that I will make available to the group. It's part of the presentation, but we also have it as an individual handout if you're interested. This is a great algorithm for providers to decide on make their decisions for PQRS reporting. So you'd start at the top. Do you plan to report for PQRS in 2015? If you say yes, you determine the group size, what capabilities you have as far as submitting via EHR, etc. And then it shows if the value modifier will apply to your group and how. So this is a really good algorithm to work with providers through to see how the value modifier will affect them. So quality resource use reports, or QRURs, they've actually been around since 2013, but they're getting a lot of attention this year because they're available now to every provider. So what is a QRUR? It's a physician feedback report that is provided twice a year. It is a summary report that's intended to provide timely and actionable information to help groups and solo practitioners understand and improve the quality and efficiency of care to Medicare beneficiaries, and to inform them about their performance on measures that are included in the value modifier for quality and cost for the groups to whom the value modifier applies. So if we think of a QRUR, it's really the report of everything in the performance year spelled out in supplementary exhibits, and it will also tell you what your value modifier adjustment is for that following payment year. So the QRURs provide comparative information so that the physicians can view examples of the clinical care their patients receive in relation to the average care and costs of other physicians' Medicare payments. They also display the quality of care and cost data that factors into the value modifier, and they can use the annual QRURs as a very detailed source of information explaining how their payment in the following year is impacted by the value modifier. And it's a summary that also includes supplemental exhibits. So 2014 mid-year QRURs, or my QRURs, are usually released in April. They look at, it's only claims information calculated directly from Medicare claims billed from July of the previous year through June of the current year, and that's released in April. The mid-year QRURs are really for informational purposes only. So it would include interim information about TINs to performance on 3 quality outcomes and 6 cost measures, but it is for informational purposes only. It doesn't include information about the value modifier for the following year, and it doesn't include the PQRS information for the previous year. So the 2014 annual QRURs are disseminated in the fall of 2015, so they're available now. And again, this is where a provider or group can see complete information that was used for their value modifier calculation. As part of my job, I work with providers and groups to access their quality use reports, and then we can drill down and see how their 2014 performance affects their 2016 payment. And this year, for groups of 10 or more, the Quality Resource Use Report shows the value modifier adjustment for 2016. Remember, in 2014, the value modifier group applied to groups of 10 or more. So they would need to look at their 2015 Quality Resource Use Report this fall to see how their payment is being affected starting January 1st. Next fall, when we look at the annual QRUR, the value modifier will apply again to all groups, group being defined as 2 or more, billing under 110. So this is a sample from an annual Quality Resource Use Report. This is the page that providers normally hone in on, and they can see their quality composite score, and you see what the average range is, and positive scores are better here. And then see the cost composite score, and here negative scores are better. So looking at this group or this sample, the provider or group can see where they are performing based on, compared to the rest of the nation. So if we see the red dot there in the lower left-hand quadrant, it shows that this particular group appears in the low quality, high cost quadrant, meaning they would receive a downward adjustment for the value modifier. The top of the key shows the value modifier. If you are providing high quality at high cost, then there's the 4 different tiers, and that's what determines the upward, neutral, or downward adjustment. So how can you access the Quality Use Report? Quality Resource Use Report. As of July 13, 2015, an EIDM account is required. That's CMS's Enterprise Identity Management System, and you're required to have that account to access your Quality Resource Use Report through portal.cms.gov, and there's detailed guidance here. We provided a link to provide you information on setting up an EIDM account. One person from your group would need to obtain an EIDM account with the correct roles, and this section will show you how to set up that EIDM account to access the group's QRUR. Once you've set up the account, you need to have the correct roles to access the QRUR, and we can give you more information on that. But let's look at what providers can do now. It's October 2015, kind of late in the performance year, but there are still some actions that can be taken. The first thing is to decide to participate in PQRS for 2015. Remember, not participating in PQRS for 2015 does result in an automatic 2% penalty beginning January 1st, 2017. Once they've decided to participate in PQRS for 2015, they would look at choosing a PQRS reporting method. Again, that would be based on the size of the group, their specialties, and EHR capabilities, and then look at which quality measures they would like to report under that method. You can also start improving to see how performance measures up. Within the EHRs, they can generate reports to monitor their performance. They can do this by looking at electronic clinical quality dashboards that are part of the meaningful use modules within the EHR. They can also compare performance to the value modifier quality benchmarks that we can make available to groups that are interested, and that's also posted on the CMS website. And also, providers and groups of all sizes are recommended to access their quality resource use reports and tune into the calls with CMS and with QIN, QIO, with HSAG, to learn how to use these quality resource reports to drive quality and improvement. And I've also provided two numbers here if anyone is interested in getting more help in understanding the value modifier. They have the Physician Value Help Desk, and there's also the QualityNet Help Desk, and those are both open from 8 a.m. to 8 p.m. Eastern Time, Monday through Friday, to offer support with the value modifier, QRURS, and PQRS. And also you can access technical assistance from the Medicare Quality Improvement Organization, or QIO, and of course that's HSAG, and I'm a health informatics specialist with HSAG. We're funded by CMS to provide no-cost assistance to providers. We can help you learn about these programs through one-on-one assistance, through our learning events, and also by providing expert advice. So that concludes my presentation for today, and I'm glad that we have plenty of time for questions.
Yeah, Carol, first I'd like to personally thank you for serving as a presenter for today's webinar. We will open it up for questions now. We utilize the questions feature built into the GoToWebinar app. So if you can, you'll find that button either on the right-hand side of your screen or at the top. If you can't find the questions button and can find the chat, feel free to enter your question in chat, and we will take the time to answer every single question. What we'll do, the format will be, I'll read the question to Carol, and she'll take care of the answer. So first question, Carol. What EOB claim codes are going to be used to indicate adjustments for meaningful use PQRS and the value modifier?
I would love to have that question sent to me via email. I don't have the answer to that question, but we can look it up and get that out to you. Remember, the PQRS penalty is at the NPI level and the value modifier adjustment is at the TIN level. So there would be both, and we can investigate that answer for you.
Okay, next question. What is the difference between calling the Physician Value Help Desk or the QualityNet Help Desk?
The QualityNet Help Desk helps with technical issues like being able to access the CMS Enterprise portal, where the Physician Value Help Desk can really be of more assistance once you have the Quality Resource Use Report in hand, if you have specific questions about the supplemental exhibits or how to interpret the reports.
Okay, next question is, will the group still have a QRUR report if they had less than 10 providers in 2014?
That answer is absolutely yes. Even though they were not subject to the value modifier for 2016 because they did not have more than 10 providers, they do have a quality resource use report, and I found that very helpful on the part of CMS because it helps those providers, although they weren't part of the program since it's being phased in, not subject to the value modifier, they can still access that information and see how they're doing with cost and quality in order to make changes so that when the value modifier does apply, as we know that will happen in 2017 based on this year's performance, some changes can be made, some questions can be asked.
Okay, next question.
So short answer is yes, there is a quality resource use report for groups of all sizes available now.
Next question. Exactly how does the value modifier work? What do providers have to do?
Okay, so the value modifier is an adjustment that's made on a per claim basis. What providers need to do for the value modifier is decide whether or not to participate in PQRS. Remember, the value modifier is an adjustment or a modification to reimbursement. So if the question is, what does a provider need to do for the value modifier? The answer to that is submit quality data and make sure that they're reflecting the high quality of care that they're providing. That's the part that we really have control over. You have to get that quality data in so that CMS can have it to calculate the value modifier, and then also make sure that the data that you're reporting does reflect the high quality of care that is being provided. So what providers need to do for the value modifier is participate in PQRS so that they don't end up with an automatic downward adjustment, and also keep an eye on the quality data that they're reporting to CMS.
Next question. Where can I find a list of all eligible alternative payment model entities? I've heard or read about CPCI and ACO, but are there others?
There are many, many others, and there's actually an interactive map that shows all of the different payment models, where those are available, and how to become part of those models. I can follow up with an email to you, Scott, to send out to the group that will include that information.
Great. Next question. Can an organization download the collaborative raw data into a data warehouse for reporting purposes?
Can an organization, can you repeat that, please?
Yes. Can an organization download the collaborative raw data into a data warehouse for reporting purposes? Maybe they're talking about the exhibit files that come along with the QRUR reports.
You know what I'm thinking they may be asking about there. I'm just going to back up. I apologize if anyone's getting motion sick. But when you look at the different ways to report PQRS, it sounds to me like the question is, how do we get our data to CMS? I think that's what the asker is asking. And when they're talking about rolling things up collaboratively in a data warehouse, they may be talking about a data submission vendor where the electronic health record rolls up that data and provides it to CMS as a data submission vendor.
Yeah, Brian, if you can submit a follow-up question, maybe something else, worded a little differently, maybe we can get you the answer that you're looking for.
Thanks, Scott.
Next question. Submit quality data via PQRS reporting codes is how the value modifier adjustment is tracked, correct?
But submitting quality codes, for me, hearing submitting quality codes means that the provider has chosen to participate in PQRS via claims. That's how it started back in 2011 when it was PQRI, and the only method that was available at that time was claims, and then they phased in the registry option. But there are many, many different ways to participate in PQRS, so no, you don't need to have quality claims codes anymore. That's not the only option to do that. It is one option, but not the only option. I hope I understood the question correctly.
All right, next question. When will the claims method of PQRS participation be discontinued?
That's a good question. We haven't had anything in writing. All of the CMS incentive programs and quality reporting are revolving around electronic health records. There is a push to use the electronic health records to submit quality data. At this point, claims is still an option, and they haven't released the claims codes for 2016, but I haven't heard, as liaison to CMS, we have not heard that claims would be sunsetted in 2016, and we don't have a date for that, but we have heard that in the future you will no longer be able to submit PQRS via claims.
Okay, next question. Is there an appeal process if a physician or organization feels that they have been incorrectly assessed with a downward adjustment?
There is absolutely an appeal process. The QRURs were distributed or made available, I'm sorry, in August or early September. The period for an informal review, and that's if you think the value modifier has been assessed incorrectly or if you're receiving a penalty incorrectly from PQRS, there is an informal review process that's available at cms.portal.gov. Actually, since we're sharing screens, if you don't mind, I could pull that up and we can look at that. This is the CMS portal for those of you that were used to submitting using your IACS account or individual authorized accounts, now the EIDM, and this is where we access those applications. If we scroll down on this website, you'll see the physician value portlet, and right here is where you can register if you're a group to use the group reporting option. You can view your PQRS and QRUR reports depending on the roles that you have, and you can also request a value modifier informal review. So looking within that portlet, we'll see here that you would click on Value Modifier Review. And just to let you know, the Value Modifier Informal Review period or window closes on November 9th.
Okay, next question. Where can the organization go online and view how a 10 is doing in relation to other 10s? Can that data be downloaded from the site in a format that can be uploaded into a structured format? Because we see value in letting our providers access this data locally to gauge our performance. So
absolutely. That's all included in the Quality Resource Use Report. So once they access that Quality Resource Use Report, it shows their performance at the TI at the 10 level compared to you know, national benchmarking and cost and quality for other tax identification numbers.
Next question. What are the common barriers to successful PQRS reporting that you see out in the field?
Common barriers for reporting PQRS, number one, is not thinking of it until it's too late to report. But the barriers that we've seen are selecting which method is best, depending on the size of your group and the specialties. We've also seen some products where the EHR has said that they have the capability, but then it may not be transferring over in the correct format. So there are different barriers, but overall, the successful participation in PQRS has been very, very positive. So it's not a very labor-intensive process. Once you have it set up, depending on your reporting mechanism, there are few barriers.
Next question is the data submitted for the PQRS program used to populate the Physician Compare website?
It is, and there's more information on Physician Compare. We actually sent out an email to find out which measures would be shared on Physician Compare, but there's more information that I can send you and a website on which measures will be used to determine the measures for Physician Compare. We can send that out to the group.
Great. That does conclude all of our questions. Carol, is there any other information that you'd like to share, either about PQRS, HSAG, or anything else?
Just to let you know, we do work with groups of all sizes to help you access your quality resource use reports, or put you in touch with the appropriate people at CMS to help you do that. We're working on diligently as a nation right now under contract with CMS to figure out the best ways for providers to interpret the information that's provided in the quality resource use reports to drive improvement. And I just, again, wanted to say thank you, Scott, for having me as a speaker.
Hey, no problem. We did have another question come in, last minute question.
Okay.
How do you go about getting around a PACS or an EMR system that does not provide a way to automatically report PQRS?
That in that instance, they may find out if their vendor is a data submission vendor, or choose registry reporting or claims reporting.
So there are other methods available.
Absolutely.
All right.
Even if you don't have an EHR, you can participate in PQRS.
Well, I would like to thank all of our attendees and our speaker for today's webinar. Please consider signing up for the future CSOHIMSS Lunch and Learn series. Again, the handouts are available within the GoToWebinar app using the handouts feature and are already posted to the CSOHIMSS website. A recording of this webinar will be posted to the CSOHIMSS YouTube channel in the next several days. I'd like to, again, thank you all for attending, and we hope to see you at a future CSOHIMSS event.
Thanks, Scott. Bye-bye.
Bye.